Hello, I came across a case that I'm about to do a clincheck for, and it's a common mistake I see made in the clincheck that is provided by Invisalign, and something I think that inexperienced Invisalign providers have to really look out for. So we have a case here that's class 1 on the left side. This side is a kind of end on class 2, weak class 1. There is a lot of lower crowding. I would call this moderate to severe lower crowding. The upper crowding is more like minor crowding. Maybe you want to call it minor to moderate crowding. And there's a deep bite. Now, the deep bite arises mostly from the fact that there is, you notice this curve of Spee. The curve of Spee is a form of crowding. People don't talk about this a lot, but you have a given tooth mass collectively, and it is distributed along a curved line so that when you correct it, if you notice in this plan, the teeth are going straight down and no interproximal reduction is planned in this particular clincheck. Now, the reason why this is significant, you might think, well, you know what? Let me give this a shot. Let me try this. If you look at it from this view, again, you see maybe there's a slight forward dimension, but you see the teeth going straight down. But when you look from this view, you see there is some forward movement of the lingually displaced teeth. Now look at the bite. It's very deep. And so the lower crowding has to be resolved and come forward. And even though the upper anteriors a little bit are coming forward, you are at risk here from these teeth clashing. Now, you notice on the clincheck, you see some clearance, some overjet, and that might give you a false sense of security that you will not have anterior prematurities. But that's based on these lower teeth going straight down. Now, if this is not readily, and that's not going to happen, there's going to be more forward movement of these teeth because that's the only place without interproximal reduction that you can get space to resolve the teeth. So you have to plan for these to come more forward than the clincheck shows. If you look here, anytime you have a case that has more crowding in one arch than the other, and it's usually the lower that has more crowding, not always, you can go to the Bolton analysis. And you see how it says mandibular excess. That means that the lower teeth are wider than the upper teeth in terms of the normal ratio. You have 8.1, 8 is your central incisors, 6 and 6.2. Those are narrow anterior teeth. And the uppers are closer to normal. They're a little narrow too, but not as narrow by proportion. So here's what I would do in this case. I would either add interproximal reduction to the lower, or I would actually ask these teeth to come down with a little bit of a tip forward, which is really how they will be, or the quickest change you can make to give yourself a little bit of avoidance of anterior prematurities. We talked about how narrow these teeth are. Now, I don't think this patient's going to want to get veneers because the teeth are generally nice, but if you look at the laterals and their shape, so I'll do is I will actually modify this. Let's hope this comes up quick. Yes, it does. And I will add some space on either side. I will explain to the patient that they have small teeth. This is a relapse case, by the way, and this may be one of the reasons there's relapse. I don't need those bite ramps. Let me take those off. And now, while it seems like a lot of overjet at the end of the treatment, I don't think we're going to end up getting that. And this, having this space here will allow you to avoid the anterior collisions. And at the end of the treatment, you can then say, hey, you know what? I have those spaces, but I don't think I need them, and just tighten them up very quickly. But you want to avoid anterior prematurities. One other thing I'll point out is a quick teaching tip. You notice how the lower midline is off a little bit. That has to be because you have the class 1 on the one side, but you have the slight class 2 on the other. And don't ever think about, with an adult especially, of distalizing these into a class 1 for two reasons. Aligners are not great at distalization unless you use a rubber bands, and adults are not wearing rubber bands. And also because the upper midline is on in almost all these cases. It's the lower, barring unless there's a missing tooth. If the lower midline is off, it is the lower midline that's off in this case, and you wouldn't want to move the upper midline over, and that's what would happen if you distalized trying to get into a class 1 here. You can give a child elastics to bring the mandible forward, but not an adult. All right, I know I packed a lot in there, and look at this result. That is going to be tough to achieve unless you plan for the lower incisors to have more space between them and add IPR as well. All right. Thanks for listening if you made it this far.